Thanks very much to all of my colleagues and for the gracious invitation to speak today regarding IBIS in CTO PCI. The changing landscape of CTO PCI and complex PCI in general requires us to step out of our comfort zones and insist on becoming better every day, getting better techniques, better with the technologies, adopting new technologies when we can find them to make our procedures safer and more efficient. So in CTO PCI, the traditional uses of IBIS in this and in regular areas have been the typical things we talk about. What are we treating in the way of plaque composition? What's the vessel size in the way of your stent size selection? Where are you going to put your stents? How are you going to optimize your outcome? Are you sure that you can do the procedure without cracking the stents open along a big calcific shelf that you failed to prepare? But the reality is in CTO PCI, where we leverage things like the subintimal space, we leverage things like the retrograde approach, we leverage the entire size and structure of the vessel. We have to change our thinking to be able to image all of those aspects of the case to really get optimal outcomes. So we've all seen this figure, and this is no new information to anyone that's going to be listening to this talk, I'm sure. But these are the four sort of fundamental pathways that we use to cross CTOs: either retrograde through the wall, antigrade through the wall, most commonly antigrade through the plaque, and most rarely retrograde through the plaque. But when we think about how we can use IBIS to facilitate these processes, we think about dividing them into facilitating crossing and then defining the tissue, the anatomy, and exactly where we are with our gear. And so I'll present a few cases here and we'll see if we can illustrate those things. So this first case is called Through the Looking Glass, which we've seen a little bit of previously. This is a case that Dimitri and I did together some years ago, where you have a fairly large obtuse marginal branch chronic total occlusion with a very ambiguous proximal cap. You can tell that the distal circ is down here. You can tell this guy comes up somewhere. There's nothing but epicardial left collaterals filling this. And we all know now that a much better approach to this might be IBIS guided proximal cap puncture and even STAR rather than going retrograde through an epicardial from a safety perspective. So looking at these diagnostic films, as I mentioned, there are largely left-to-left collaterals, but there's a fairly big, healthy landing zone. So this also becomes a very acceptable case for ADR, so long as you can actually get into the proximal cap without putting a hole in the side of the vessel. And that's the really big challenge that we're dealing with here, isn't it? And that is safely entering the CTO target zone. So selective injections were done here to define all of the collaterals to see if there were any safe things that we could use. And then we consider the hybrid algorithm and the usual things that we always consider when deciding which strategy we're going to use. Ambiguous proximal cap suggests retrograde might be better. Poor distal target suggests either retrograde or antigrade, depending on what part of the target is poor, whether or not there are good collaterals or bad collaterals. Bad collaterals might suggest you go towards antigrade, right? So in this situation, there was clearly an ambiguous proximal cap. That would suggest antigrade, but that would suggest against antigrade and go to retrograde. But then there was a poor distal target. So that would go against retrograde and say, let's try antigrade. And then there were appropriate interventional collaterals for some people, but they were largely epicardial. So that would maybe suggest retrograde for some or antigrade for others, right? So how do we get clarity here? And that's where you can use the intravascular ultrasound to perform the IBIS guided proximal cap puncture, where here you mark the proximal cap with the IBIS fluoroscopically. If you have a large enough guide and a thin enough IBIS, you can do this on real time. And then you puncture at that fluoroscopically co-register landmark using a directed penetration wire into the proximal cap. And then you can confirm with your retrograde injection that you've successfully entered the structure of the vessel. Now, this is clearly subintimal, where you can see this separation between the wire and the vessel. But that's still a win, right? Because we leverage the subintimal space. This is confirmation on the IBIS as we pull it back that we are in fact in the vessel architecture with our entry wire, right? This wire is well within the CTO segment in the interplaque area. Then it comes down to what we know how to do, which is deliver a stingray and then perform antigrade dissection reentry. You can see the dissection and reentry wire exiting through one of the side ports of the stingray with a true lumen wire position. We can confirm with IBIS, and in the interest of time, I'll move through that to yield this final result. Okay, so that's one way. That's facilitating entry. How about if you're coming retrograde? Well, this is the fundamental diagram describing reverse cart or retrograde dissection reentry, where you get two wires in opposite sides of the vessel, but both within the subintimal space. And then you take a balloon along your antigrade wire, destroy the tissue planes between both wires so that you can then move your retrograde wire into the same space as your antigrade wire. So the top 5 reasons for difficult reverse cart: there's a small balloon, the balloon is too small, the vessel is larger than the balloon is smaller than the vessel, it's a small balloon, and you're chicken. These are the words of my mentor, Dimitri Karmpeliotis. But the real reasons for a difficult reverse cart are reverse carts not performed in the optimal position. There's too much vessel tortuosity, so your wires can't connect because you can't torque. There's too much calcification, so you can't actually create a common space. The balloon dilation is not performed all the way back to the true lumen proximally. And then knuckles have caused big hematomas. So the space that you're using is large and your wires become far apart. So obviously you want to try to perform reverse cart in an area where your wires are closest together. And so this is a way to do that, right? So this is one case where it's fairly nasty looking CTO, very proximal cap there, with reasonable retrograde interventional collaterals from the septum. So the retrograde ends up being crossed without too much difficulty. This is sort of a usual standard septal type of configuration, as you can see. And then once we've confirmed retrograde wire position, we're very near to the proximal cap. There's an antigrade Carlino that's performed to get going and a retrograde Carlino that's performed to get going. And then you now have, in this dancing view, knuckles, both retrograde and antigrade. So in the same tissue plane, in the same structure of the same vessel. And so now you're able to perform your reverse cart. The challenge is you can't seem to make the connection. Why is that? And how can you sort that out? One way of sorting that problem out is to advance an IBIS and confirm that not only are your wires both in the subintimal plane, but here is where they are the closest together. And in this situation, it actually almost seems as though they're in the same plane, right? So you may wish to then advance or retract your base of operations to find a place where the 2 wires are in different tissue planes so that you can then perform reverse cart and ensure that one wire can enter the other tissue plane. One way of facilitating this as well is to bring a guide extension catheter down on your antigrade wire to the point where you know the 2 wires are in a slightly different tissue plane, and then you can almost drape the antigrade subintimal tissue across the top of your guide extension catheter to create a drum that you can poke into when you've identified the optimal space to do your connection on IBIS. So this was the inflation at the optimal point, and these are your final results on the right side here. That's what it started with, and that was the end. And as a, I'm just going to skip through this last case because we've, this second last case because we reviewed this already through one of my colleagues. But this is another way of defining the use of IBIS, and that is to understand the anatomy that you've created. So this was a diagnostic angiogram for CTO that I did some time ago. And unfortunately, for a variety of reasons, we failed. And so we had to do an investment procedure. And when we did an investment procedure, we dissected into multiple tissue planes. So you can see you have TIMI3 flow into this RPL system. You have TIMI3 flow into what I think is the starting of a PDA. There's a couple of different branches coming out. We're reasonably happy with this, and we decided we're going to go ahead and invest. Now he comes back 8 weeks later saying, I'm feeling better, but not 100%. But shockingly, what you see is 1, 2, 3, 4 branches towards the end of the vessel now, whereas before you only had 2 real branches at the end of this vessel, right? 1, 2. So you now have double the number of branches, right? This is why he feels better. This is probably the lesion that's causing him his problem, this 90% proximal. There's a nice myocardial blush distally. The challenge is there's a big dissection flap right in the middle of this large bifurcating branch distally, and that dissection flange goes all the way up the vessel. So how do you manage this problem? Because if you stent in the mid vessel and you cover the entry point of this probably false lumen into this true lumen channel that then differentiates into multiple true lumen channels distally, it's like you're going to have to pick one of the kids, right? Where you're going to shut something down. So one way to optimize this is by identifying by IBIS where the precise connection is between all of these lumens and stenting just proximal to that, given that distally there's TIMI3 flow into all these branches, and proximally you have a tight lesion that's likely responsible for the patient's symptoms. So when we review the IBIS, and I'm just going to scan backwards quickly here, we see that here we're true lumen, and here we're false. So what we need to do is fluoroscopically co-register right there, which is the connection between the true lumen and the false lumen. And that helps us identify exactly where we're going to end up putting our stents, right? The rest of this is all true. There's a small segment of false up top there, right? And so that's what we ended up doing. We recognized that this was a massive vessel, and we placed a big proximal stent just proximal to the area that we co-registered with the IBIS to define where the connection was between all 4 of those lumens, 2 of which were supplying one set of dissection planes, 2 of which were supplying the other. And after stenting, all 4 branches are home. He continues to have a very nice myocardial blush. These all connect to the true lumen, and he's back to work and asymptomatic a year later. So IBIS allows us to clearly delineate not only where we need to make connections, but what the nature is of the tissue that we're creating and the tissue that we're stenting. And then, of course, where the connections occur between the various lumens that we're creating during CTO PCI. The use of IBIS now is no longer the new way, it's the standard way. And to really do CTO PCI well in the future requires precision and requires us to use the very best techniques and technologies at our disposal. Thanks very much for your time and attention.
A question for you. Is IBIS an option in these complex cases, or is it a must? And in what percentage of your cases do you use intravascular ultrasound when you do CTO?
Yeah, that's a great question. I mean, in my opinion, and I realize that there are differences in different markets across the world, but in CTO PCI, I IBIS 100% of my CTOs because they're too difficult. The procedure is difficult as it is, right? Why make it harder by trying to guess, right? The tissue is calcified. The tissue is difficult to expand. The tissue is difficult to understand. So, we need more information than the angiogram provides. I recognize that even in the North American environment, the average uptake of IBIS is like 12% versus in Japan, it's, over 90%. Why is that? Well, it's not because operators are so much better in Japan than they are in the US. It's because of the fundamental differences in the system and reimbursement and time and logistics. And we as physicians, I think, need to just move beyond that. If we're going to take on these complex procedures, we just need to accept the fact that we have to do them right. There's recent evidence coming out showing that if you lose a 2-5 side branch in a CTO, your MACE rate goes up, so that you should never have done the case in the first place. These are the types of things that the use of intravascular imaging can prevent, and the use of intravascular imaging can facilitate in the way of safe procedures. And that's really why it's an absolute must in the 90% of procedures that I do it in. The only ones I don't do it in are the ones where the patient's too sick or we're doing something else or I can't get the darn device down. And that's the minority.
I couldn't agree more. And it's also beyond safety and success, but also durability of the procedure. So I personally use 100% intravascular imaging in my cases.
Yeah.
One second quick question. I would give this to Emad if he's still on. Emad, talk to us a little bit about the Gaia wires. Is this just another wire, or do people need to have some kind of familiarity both with engineering and the way it should be used? Because we've seen some great results with the Gaia wires, but we have also seen some not so great results. So what's your advice? Do they need to get some proctoring? Do they need to go through some modules? Is it the same wire or is it something different?
Thanks, Dimitri. Yeah, I mean, Gaia wires are not first choice wires for antigrade wire escalation. And the reason is, that's my personal opinion, it has tapered tip. It does give you that tactile feed that sometimes you miss with the Pilot 200, for example. But the fact that it has a tapered tip, it can go into micro channels or bridging collaterals that, unless you're sure that where you're going with an antigrade, when you go antigrade, it can cause harm actually and perf. So it is also like the Gaia 2, for example. It's 3.5 grams. It does have a lot of tip load, so you can actually develop that, deploy that tip load into a lower area, so it gives you more penetrating force. But that could also could be a weapon against you if you don't know exactly where you're going with that wire in. I think there are safer wires to use initially before you pick the Gaia wires, like the Pilot 200, for example. So before using it, I think, yes, asking your more experienced operators getting proctored about it a little bit also is a very good idea.
Yeah, I agree with you. I would add that in addition to the tactile feedback, which is not that great with the Gaia either, it's also a visual feedback, as you showed in your case, when it's a little bit stressed and so on and so forth. And also they can exit through the body of the CTO, which is very almost unheard of with the hydrophilic wire. So my recommendation, my advice to operators is that it's not just another wire. It has different properties and they need to know exactly how to use it, and their modules and their proctors, and they need to seek advice before they use them. Also, the Gaia Next wires are completely different animal. They have higher tip loads. So what used to be Gaia 2 is now Gaia 1 Next, and the Gaia 3 is an extremely penetrating wire, so people need to be very, very careful. And the last brief question, if we have time, is for Juan. Can you give us some tips and tricks to increase the success of antegrade dissection reentry, like avoiding, for example, antegrade injections, or using routinely a guide extension, or aspirating before you do your reentry, and so on and so forth?
Yeah, so it's a very good question. I mean, at my center, we use predominantly an antegrade approach. I really feel that as you pursue antegrade reentry, you need to be aware of the size of the subintimal space that you're creating, particularly in obviously ADR, because it may actually not only lead you to fail, but even if you succeed at getting the true lumen distally, you might be left with doing either a more complex stenting strategy because of the degree of the dissection planes, or resorting to investment procedure. So I would say one of the main things is to try to reduce the size of the subintimal space. Sometimes you can use a guide extension to try to prevent the amount of antegrade flow going into the dissection plane. Obviously, I would avoid basically antegrade injections at all costs, particularly when you feel that you've re-entered the true lumen. And then the last technique, particularly when you're doing ADR, is to focus on doing appropriate straw, because often it can increase the viability of dissection reentry. So I know that, we use straw all the time with the Stingray, but with the recross, there's the opportunity to basically do almost live straw as you try to poke the subintimal space, because even in between wire exchanges, you can actually get seeping of blood into the subintimal space. So I would say straw would be first and foremost for ADR. But I think the most important thing is to be always mindful about the subintimal space, even as your procedure progresses, by, again, using a guided extension, preventing antegrade injections, or even as you do wire escalation, to be cognizant of the knuckling, because often, as you knuckle through, if you're not using an ADR, if you're trying to do antegrade wire escalation, you're creating a subintimal space that's large enough that ADR procedures will not succeed at a later time, even with straw.
And I would add that just stay tuned, because there are new re-entry devices that are in the pipeline right now that will do exactly what you said. They will allow more effective straw, essentially aspirating the subintimal space and restoring visualization of the distal vessel, and making kind of collapsing the tissue plane so that you can make the re-entry easier. And also, don't forget the crossbows, which I don't think it's a very good starting device. But once you get into the subintimal space, if you want to complete your last few millimeters of dissection, it's only a 1 millimeter automatic knuckle, so to speak, catheter, and that facilitates re-entry by reducing the amount of injury to the subintimal space. So be very, very careful. I agree with you with the amount of damage and hematoma that you create to the subintimal space. Thank you very much, gentlemen, and then we're going to go into sections.